Hello, everybody. My name is Anthony Mato. I'm the director of the CLL program at Memorial Sloan Kettering Cancer Center. I'm representing Dr. Brian Kaufman and the CLL Society and doing interviews with some of the stars from the ASH 2021 meeting. We're really interested to gather information about what are the new and hot topics in CLL and bring that information directly to patients. Today, I'm joined by Dr. Megan Thompson, my colleague, also from Memorial Sloan Kettering Cancer Center. Hello, Dr. Thompson.
Hi, Dr. Mato. Nice to be here.
Thanks so much for dedicating some time to this interview. You had a couple of really key poster presentations at the ASH meeting that I think are very relevant to patients. So I was hoping we could spend a couple of minutes just summarizing each of those presentations and really bring it down to the level for patients. So the first presentation I wanted you to talk about were the outcomes for patients who were double exposed. And maybe you can just start off by defining that patient population and then take us through the data.
Absolutely. So when we talk about a CLL patient as being double exposed in 2021 and coming in 2022, really we've entered this era of targeted therapies and very effective targeted therapies, mainly the BTK inhibitors, including ibrutinib and acalabrutinib, and the BCL2 inhibitor Venetoclax, and combinations of and monotherapies of both agents are commonly used now in clinical practice and really lead to remissions in a majority of the patients. However, an emerging situation that we're having in the clinic is what to do after patients have been exposed to both a BTK inhibitor and Venetoclax, and we're calling that the double exposed patient population. And
just to interrupt you for a second, and that's important because those are the two main classes of drugs that patients with CLL are likely to have as part of like standard of care, correct?
Yeah, exactly. I think you would agree that we're seeing a shift, whereas in the past, many patients maybe had chemoimmunotherapy as part of their treatment. While that remains an option for a very small number of patients, most patients will now not be treated with chemoimmunotherapy and will be treated with, even in the frontline setting, one of these novel agents, ibrutinib, acalabrutinib, or Venetoclax.
Okay, and so then take us through kind of what happens to patients after they've been treated with these drugs and why this is an important topic.
Sure. So, as we were saying, many patients, and as they were approved, and you'll hear data from the ASH meeting where these drugs are now being combined, but many patients receive, for example, a BTK inhibitor like ibrutinib, and then at the time of disease progression, maybe had Venetoclax in combination, either alone or in combination with an anti-CD20 antibody like rituximab. So there is a subset of patients that develop progression of their CLL after receiving, one or both of these agents now. So we focused on patients who needed treatment for the CLL after getting both Venetoclax and a BTK inhibitor. And this is really important, I think, to focus on because there's just not a lot of studies that have been conducted, particularly in the clinical trial setting, looking at patients who've had exposure to both of these agents. And one of the reasons I think that this is important is because there are, different, certainly mechanisms of resistance with the BTK inhibitors compared to Venetoclax, and we're still learning a lot about what makes resistance to these targeted agents. But these patients need therapy now in the clinic. And so we kind of decided to focus on this patient population because it is an emerging issue in real-time clinical practice now.
So from your observations, is there any obvious approach that makes the most sense for this patient population?
I don't think so. And that's part of what our research tried to look at. What are clinicians doing in clinical practice? And so just to go into a little bit of what we found, so we identified 125 CLL patients who had received a BTK inhibitor and Venetoclax and then needed a line of treatment after. And really the goal of this project was to look retrospectively. This is a multi-center international group of physicians and centers treating CLL patients to see what practice patterns are and what the outcomes for these therapies are, because I don't think that there's really a clear answer.
Okay. One thing I noted from your abstract was that there did appear to be a role for non-covalent BTK inhibitors. Obviously, that's not an approved class, but maybe you can kind of share with the audience what this is and what the data from your abstract looked like specifically.
Absolutely. So non-covalent BTK inhibitors were really designed to overcome the resistance to the covalent BTK inhibitors. So to go through some definitions, so covalent BTK inhibitors refer to how the drug actually binds to the target protein BTK, or Bruton Tyrosine Kinase. So the covalent BTK inhibitors, they bind irreversibly, and these new agents bind basically in a different manner. The non-covalent inhibitors, they bind reversibly, and in binding in a different manner, the hope is that they'll overcome the resistance to the first class of agents. And we've seen really promising clinical data for this class of agents. It includes pirtobrutinib, formerly LOXO-305, or nemtabrutinib, formerly RQL-531. And we saw updated data for those molecules at this meeting as well. But looking at our retrospective data, certainly we had many patients who were treated with a non-covalent BTK inhibitor. We had 43 patients, and the overall response rate was 75%. That's very good. And I'll go into some of the other groups, kind of what their response rates were. And we also looked at the progression-free survival, or basically when patients are treated with the non-covalent BTK inhibitors, what is the median time to progression? And for this cohort, that was not reached. So actually there were ongoing responses. So there was a hint, although this is retrospective data, and we didn't, single out, this is all the non-covalent BTK inhibitors as a class together, with a median progression-free survival not being reached at 9-month follow-up. It's promising that not only do patients get responses with these agents, that there's maybe the potential for durable responses here. So I think that really highlights that this could be certainly a patient population where the non-covalent BTK inhibitors could have immediate clinical impact.
And so then just following up on that, your second abstract, which I also wanted you to just briefly highlight, looked at a smaller number of patients who had been treated with and discontinued a non-covalent BTK inhibitor. So this is kind of taking it one step further. Were there any key observations from that data set?
Yeah, so the second abstract looked at both CLL patients and patients with Richter transformation of CLL, and that had received one of these novel non-covalent BTK inhibitors. And there's absolutely no data currently to guide management after patients progress on the non-covalent BTK inhibitors. So despite the promising and really potentially durable responses we saw in the other data set with the non-covalent inhibitors, we have encountered some patients who do have progressive CLL despite treatment with these agents. So we looked, it was a small number of patients, 42 patients who had discontinued a non-covalent BTK inhibitor. The vast majority of these patients was actually due to progressive disease, not toxicity or other reason for discontinuation. 32 of those patients went on to get another line of therapy. Because it was a small number of patients, these are really hypothesis generating data, but areas that looked promising, there were a couple. One that I'll highlight would be CAR T-cell therapy. There was a small number of patients who received CAR T-cell therapy after discontinuation of the non-covalent BTK inhibitors. At a very short follow-up, there were responses with CAR T-cells. So I think that should be further explored in clinical trials in this population. And then the other thing we showed really for the first time is that for patients who had a covalent BTK inhibitor like ibrutinib or acalabrutinib, and then had a non-covalent BTK inhibitor and had progressive disease, but had not previously had Venetoclax, we did show clinical activity of Venetoclax if the patient hadn't had Venetoclax before following the non-covalent BTK inhibitor. Chemoimmunotherapy, I'll note, had very poor outcomes for both the CLL and Richter's patients. So I think overall, this is kind of a glimpse into the future, and we're hoping to update this data in the future to really guide clinicians in this area. But it kind of provides a first look. And it also gets us thinking, I think, about, as does the other abstract, where will these non-covalent BTK inhibitors, particularly pirtobrutinib, which showed longer follow-up, a large number, over 250 CLL patients had efficacy data now, in the data that you presented, Dr. Mato. And we're starting to think about, will this agent be approved in the near future, and what patient population will this agent be used in? Where will it fit into the CLL sequencing paradigm? And so I think this study will help a little bit with that as well.
60 seconds or less, what was the most exciting piece of data you saw at the ASH meeting?
So I was really excited by the pirtobrutinib study that you presented, Dr. Mato. This, again, is a non-covalent BTK inhibitor. And I really liked the way the data was presented, focusing on patients who had previously received a covalent BTK inhibitor. I felt like the safety profile is outstanding, less than 1% of patients discontinuing for toxicity, which we know has been a problem in the past for drugs like ibrutinib, for example. And then the efficacy data was really promising, especially in those double exposed patient population. I think at about 9-month median follow-up, there was a median PFS of about 18 months, which I think is very promising.
So taken together, it sounds like you're defining a population with an unmet need. Those are people who have had a covalent BTK inhibitor in Venetoclax. You're identifying potentially new classes of therapies for those patients, and then exploring a new frontier, what to do beyond the non-covalent BTKIs. Very important work. I think it really highlights the value of real-world evidence. So thanks for doing that, and looking forward to having further conversations with you as we kind of explore other topics of interest in the future. Thanks for bringing it down to the level of patients. Everybody really appreciates translating the scientific discoveries from the ASH meeting. And again, looking forward to future conversations. Thanks so much for being here.
Thank you.